So next, we're going to talk about assessing bowel function. And when we're assessing bowel function, we've got to ask about the BM. Patients are sometimes reluctant to share that information with us, but just as in the course of your regular assessment, usually you're going to ask, when was your last bowel movement? If they talk about any problems, if it's maybe been a couple of days, we want to ask, is that their regular pattern? We want to ask some questions to get a sense of what their typical bowel pattern is. If they're having bowel problems, then we want to assess diet and exercise, both as contributing factors, but also to see maybe if it's beyond that, if there are other things going on. When we're examining the abdomen, you always auscultate, you always use your stethoscope and listen before you touch, before you palpate and percuss the abdomen. That's because when we start handling the abdomen, will increase the bowel sounds. So we should hear bowel sounds in each quadrant of the abdomen. And we want to note, are they pretty regular? Are they very hypoactive? We hear just a few creaks. Are we hearing lots and lots of gurgles? That would be hyperactive. If bowel sounds are absent and they're not expected to be, that's something that needs to be addressed immediately. So after some surgeries, we might expect not to note bowel sounds right away. But if a patient has an intestinal concern, absent bowel sounds can indicate a serious complication. So we want to assess that. And we want to assess their fluid balance, their skin integrity. If they have bowel incontinence, that can affect skin integrity pretty badly. If they have constipation, we want to assess for bloating, cramping. Are they having to strain to defecate? Is the stool dry and hard? Is it painful to pass? Because sometimes people will say they're constipated, but what they're describing is a pattern that's within the normal range. It's just not what they believe they should be doing. We also want to ask about a change in their normal patterns. So if they've had a change in bowel patterns, that may be more significant than if they always go only every 2 or 3 days. For diarrhea, we would be asking about frequent loose stools. Do they have cramping and urgency? To assess for impaction, we might do a digital rectal examination. You need to understand that there is some risk to that. We need to make sure that we are assessing the patient adequately because we can stimulate the vagal nerve and cause a decreased heart rate. Some diagnostic tests that might be done during assessment for bowel function would be a fecal occult blood test. It's important when we're doing a fecal occult blood test that it's not contaminated with urine or menstrual blood. We should get 3 specimens from 3 different defecations. And if most of you have probably done these. If you haven't done them, it's a card. And on one side, you apply the sample. You use a little wooden applicator to place a small amount of stool on the card window, following the instructions. You close that side. And then we used to do these bedside. Most facilities want them sent to the lab. If you're doing it bedside, you flip the card over, open the other side, and then you apply the developer to that side. And you can see the windows where you applied the stool. A blue color indicates the presence of blood. But most facilities now want those sent to the lab because they can't bill if it's done bedside. So if it's going to the lab, then it's labeled and goes into a bio bag. Some things that may cause a false positive fecal occult blood test: red meat, fish, poultry, raw vegetables, and some medications. So this is not a definitive diagnostic tool. This is a screening tool for blood in the stool. Stool that has blood in it, we may see fresh red blood if their bleeding is from lower in the GI tract. Stool that comes from higher in the GI tract is actually going to be black and tarry, or blood, sorry, if there's blood in stool and the blood is coming from higher in the GI tract. By the time they pass that stool, the blood will be black and tarry. If we're sending a stool culture, the stool should not be contaminated with urine. If for some reason we're culturing solid stool, that's collected with a wooden applicator. But usually the reasons we're culturing stool have a lot of those reasons cause diarrhea. So more often we're going to be collecting liquid stool. So we pour that liquid stool into the container. It should be labeled and go to lab for testing. Just a hint, it's a lot easier to label a specimen container before you add the specimen than after. Cultures need to be sent as soon as they're collected because that's going to affect what grows out. So those need to be sent soon. A colonoscopy is a procedure performed by a provider. A lighted instrument is used to view the colon and collect samples for biopsy. They can also remove some polyps in the course of a colonoscopy. This requires a clean bowel, and so colonoscopy prep is worse than the actual procedure itself. So the prep usually involves, we used to use Go Lightly, that would do enemas. Now some providers are having the patient do a clear liquid diet for a day or two and then use like Miralax or something that's a lot less, causes less discomfort. But the prep is always the worst part. The procedure is usually done under conscious sedation, and then afterward the patient is recovered, and the recovery is based on the sedation. A sigmoidoscopy is when this is done just viewing the sigmoid colon, and the process is the same. Okay, the last thing I want to talk about in this section are general bowel health promotion measures. When we are teaching patients how to maintain healthy bowels, fiber, fluids, activity. Okay, plenty of fiber in the diet, plenty of fluids so that fiber absorbs the fluid, bulks up the stool, makes it move along faster. And activity. The patient needs to be moving themselves to promote peristalsis. Probiotics may be recommended for some patients, especially patients who have maybe chronic diarrhea or who have some other things that indicate poor balance in the gut microbiome. There's not a lot of research, but there is quite a bit of anecdotal evidence that probiotics are helpful for things like persistent diarrhea after a stomach bug, antibiotic-related diarrhea, and they cannot effectively treat C. diff, but they may reduce the risk of C. diff if a patient on antibiotics is eating some or taking some probiotics. Okay, in the next section, we're going to talk about some potential problems in the GI tract and management of those.